Welcome. Welcome, everyone. Just going to give it a couple of more seconds here. So the chat is enabled. Tell us where you're joining us from today. All right. Okay, I'm going to go ahead and get us started because we've got a lot of information to share with y'all today. Okay. So first off, welcome. I am Megan Claire Chase, and I am the Breast Cancer Program Director and host of our BC Life podcast here at Share. And we are super excited to bring to you today part 2 of our series, DCIS Research, De-escalating the fear of recurrence. Now, I'm also a 7-year breast cancer survivor, and want to give you a little bit of information about Share if this is your first time joining us today. So Share Cancer Support, we're a national nonprofit that supports, educates, and empowers anyone who's been diagnosed with breast or gynecologic cancers, and provides outreach to the general public about signs and symptoms, because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about our upcoming webinars, support groups, our helplines, and our podcast, please visit us at our website, sharecancersupport.org. Now, we have a few housekeeping reminders for you. All participants will be muted during this presentation. Now, feel free to write comments in the chat and engage with each other. But don't forget, when using the chat, make sure you select everyone so we can all see your comments and what you're trying to say. Now, once the speaker finishes presenting, we'll begin our Q&A discussion. So please submit any of your questions through the Q&A section at the bottom of your screen. And remember that the speaker is unable to give specific medical advice. So please keep your questions general in nature. We also have closed captioning available, and you can enable that feature by clicking the live transcript button on the bottom of the screen and selecting the subtitle option. Now, this webinar is being recorded, and we will share the recording in a few weeks with all of the registrants, and it will be added to our website. So now I would like to hand it over to our 2 amazing, brilliant speakers to introduce themselves. Dr. Hwang, the screen is yours.
Hi, MC. How are you? Thank you so much for that introduction. And I'm really excited to be here. I think webinars are one of the best ways to get information out to the community. And I'm really grateful for the opportunity to be able to speak with all of you today. I am a breast cancer surgeon, and I've been interested in DCIS for probably my whole professional career. I work at Duke University, and I'm the director of the breast cancer program there. And now you're really in for a treat because Deb, my good friend and colleague, is going to share with you some of her thoughts about risk assessment. So Deb, take it away.
Thank you, Shelley. And I will very briefly introduce myself so that Megan Claire can see if there were any questions that might be good for you to answer as I get started. I am president of Patient Advocates in Research. I am a 2-time breast cancer survivor. One of those was surrounded by DCIS. And I've worked with thousands of patients through the years because I've been doing this for a long time. And I actually work on some grants for DCIS with Shelley and other colleagues, both patient advocates as well as researchers and clinicians. So I think with that, I will go ahead and see if there are any questions for Shelley, and I will bring up my slides at the same time.
And I'm just going to type in my answers so I don't cut into your talk, Deb. So I have 3 questions in chat, and I'm just going to type in my answers for all of you.
Okay.
Thank you.
All right. Well, we're going to start with a poll question. So please get ready. And I think, Victoria, you're going to have the poll ready for everyone. We would like to know what sounds better to you. So there are 7 options here. One is a non-cancerous lesion, and this is as far as DCIS. Stage 0 breast cancer is number 2. Abnormal cells that look like cancer, precancerous lesion, a non-obligate precursor to breast cancer, non-invasive breast cancer, or breast disease. So please pick one of those, and we will see what you have to say about that. And as you are doing that, I'm going to go ahead and go to the next slide because we have a lot to cover there. So Victoria, let us know when it looks like it's closed, and then we will show the results here.
Okay, sharing
Okay. Great, thank you. So it looks like, as we thought it might, that there is a wide range of what people prefer as a term. This is why it's so confusing, right? Because all of these terms are used. And I'm in the second part of what Shelley's already gone over as far as the research and what we've found. I'm going to try to put in what we're doing about trying to change the way DCIS is discussed and treated. So as you can see here from this chart, this is something that we've been working on, meaning all of us who have been doing these studies like the COMET study and precision study. This column is the current concept of what is done, and unfortunately, all the terms that you hear when you hear DCIS are related to cancer, and all the doctors that you see about DCIS are related to cancer. And yet, as Shelley said, there are different types of DCIS. So the first thing we're trying to do is get everyone, including healthcare providers, to understand that there are different kinds of DCIS that need to be treated and considered differently. And that DCIS is a condition that we still have a lot of unknowns about. This one about risk is very important. In fact, many of the numbers that Shelley gave you, as far as what the studies have found so far, are what we call relative risk. And that's a risk that is often reported in studies. It sounds very high as far as the differences, but that's really for a whole population of people. It's not for an individual person. And so what you always want to ask for your particular situation is, what is your absolute risk? And that's something that we'll talk a little bit more about here. The thing to remember is that if you decide to have surgery and other treatments, even surgery by itself, and we'll look at that in a second, have some risks and sometimes some complications. So it's not like it's either all or nothing. There are things to consider for that. As Shelley said, not all DCIS leads to invasive breast cancer, and we will see about that. And it certainly doesn't always cause invasive breast cancer. Some women who end up having invasive breast cancer later, after DCIS, have a completely new cancer. So that can happen as well. And I'm not going to go into detail about any of these things, but just so you know, we're trying, and it would help if you also push this forward to help us, that DCIS by itself is just too general. There really are, as you've seen, low risk and higher risk types of DCIS. As far as other things, I'll just kind of keep this in mind. Stage 0 is kind of what we've all come up with because it's still on the scale of breast cancer, but it's like, 0. So we don't know exactly what terms will be the best. And as you saw, everyone has a different idea of that. So I did want to go through a little bit of what we've come up with as far as tools for the COMET study. And this lists the advantages and disadvantages for surgery in a way that hopefully helps women, and it did seem to help the women who enrolled in COMET understand more of the things they wanted to consider that were right for them in their lives when they were talking about getting involved in COMET, which was a randomized study. So they didn't get to pick whether they got surgery or whether they got active surveillance or active monitoring. We actually changed that term too, because surveillance is a big word. And so we changed that to active monitoring. So in surgery, obviously, it removes the DCIS, which can lower the risk of invasive cancer, not necessarily lower the risk for, excuse me, a DCIS in the future. And about 1 in 10 patients with low risk DCIS do have some cells that may become invasive, and surgery removes that. And that, there is closure because you have surgery. It seems like everything is okay. There can be upstaging as well. On the downsides of surgery is that you lose some of the breast or all of it, depending on what surgery is chosen. There can be side effects, as we mentioned. Sometimes there's a need for a second surgery because in surgery, they may not have been able to get the whole piece of DCIS. Sometimes it can be very difficult to see that and get it out. So those are things that can happen. As far as active monitoring, which again is what was mentioned as active surveillance in some of the studies that Shelley presented, there you can avoid the effects of surgery and radiation, which are those skin changes and things like that we mentioned. About 8 to 9 of 10 patients are able to stay on active monitoring for at least 10 years. That means that they don't have another breast event, whether that's DCIS or invasive breast cancer over a 10-year period. So 8 to 9 out of 10, that means 1 to possibly 2 people in a 10-year period may have either another DCIS event or a breast cancer. And the thing to remember is that active monitoring is truly active. It is monitoring through mammograms what's happening in the breast. So if there are any kind of concerning changes, that person can have surgery and any other treatment. So it's not like you never have surgery or never deal with it. You only deal with it at the time when you need to. And so some of the downsides are that it can actually create more anxiety. Some women don't just want it out. They don't want to have to deal with it and we have here, these things were made for the COMET study. Most women who are doing active monitoring on their own would not have a mammogram every 6 months. They might have it every 12 months. And in fact, now that when women are on the COMET study and are done in the 5-year period of the really careful tracking that we're doing, they actually can go to mammograms every 12 months. So, and Shelley may want to talk about that at some point when we're in the discussion phase. You do need to keep up the active monitoring if you want to make sure that we catch those breast changes if they're happening. And there could be more extensive treatment later. That's really kind of unknown at this point, but we put that down anyway. One of the real issues is that women with DCIS often don't have a home, right? You get lack of support and understanding from support groups, sometimes if it's general breast cancer groups instead of DCIS, and everybody has an opinion. Unfortunately, there's just not a lot of facts sometimes to back that up. And the important thing to remember in context is that everyone who has DCIS has their own situation that may not apply to someone else. So when you're talking to someone with DCIS, their experience may be different. So that's something to keep in mind. So we did put some COMET materials together that I think could be very useful. And we're talking about how we can put these into place so that they're available for anyone who has DCIS, not just a COMET study participant. But it kind of gives you an idea of what's involved with surgery, what's involved with active monitoring, what is the aim or the goal of surgery versus active monitoring. And then if you have surgery, what happens to the breast area, and a little bit about it. So this is just the beginning of that piece that we've put together. This shows you that we have that information with more detail. So it includes things like details of the treatment approach between surgery and active monitoring, what's involved in hospital stays, what kind of time off work or usual activities do you need to be considering or thinking about for both arms, sorry about that. endocrine therapy, which is the hormone therapy that Shelley mentioned, and also common side effects for both surgery and for active monitoring. And then less common side effects, because we wanted to give women a really good view of what they could expect if you have surgery or if you do active monitoring until there might be a need for surgery. And so, we tried to make that as balanced as possible. So that information is actually available on the websites down here at the bottom, which is cometstudy.org and also DCISoptions.org. So those are two websites that are useful. The other grant that both Shelley and I are a part of is called Precision, which stands for Prevent Ductal Carcinoma in Situ Invasive Overtreatment Now. That's why Precision is easier to say. And so as a part of the patient leadership team that's there for patient advocates, we helped them design a website, and that website is still available. The grant itself, Precision, the research program has ended, but the material is still up there, and I think they have plans to keep it that way. We have done things that we call plain language summaries of some of the research that was a part of the Precision grant. So you can see on the website, which is down at the bottom here, DCISprecision.org. There, if you go to publications, you'll see many plain language summaries to help explain what that scientific research project was about, and the publication that came from it, we tried to put in plain language. We also put together this sheet, which is a 2-page sheet that talks about low-risk DCIS research as far as updates and resources. So we talked about what Precision, the research grant was, what current knowledge is about DCIS, what grading is all about with DCIS, and why there are different risk levels based on that, as well as some other factors, what current treatments are and possible overtreatment, clinical trials that are available, how to improve communication about DCIS, and then new resources. And as you can see here, it includes our plain language summaries, as well as a video on is DCIS really cancer or not. And then there is a decision support tool that I'll be going over as well. And then some other publications and references. So this is the decision support tool. And I thought I would very, very quickly run through this to give you an idea of what it is. And this tool is on DCISoptions.org under Managing Decisions. So when you go to this menu, you'll see one that says Decision Support Tool. And when you click on that button, you see it explains a little bit about the tool and then a little bit about some of the terms and things that it's going to be using. Like, what is uncertainty? Well, uncertainty is things we don't know, right? And unfortunately, those of us who are diagnosed with a serious condition or illness or disease face uncertainty every day, and we learn to live with that. So there are risk estimates. How likely would you be for a future condition to happen, like a future DCIS or breast cancer? And so that's part of it. And then what the tool is about. In addition to that, there are other questions like, what do I need to know to use the tool, the decision tool? So you can, if you know what level of risk you had based on your grade of tumor, low, intermediate, or high, then you check that box that you want, whether it's low risk or high risk. If you don't know, there's a don't know box, and we'll talk about that. And then there's information that you can click on right there about if you want to know more about choosing no surgery for DCIS and active surveillance. And again, that's also called active monitoring. Also, what about no surgery for DCIS? So there's a little bit here, and there is a study, that's the COMET study, that has been testing and continues to gather data about active monitoring, so that we're still gathering data on the women who enrolled in the COMET study, and there will be results, but we don't have them yet. We're hoping later, and actually Shelley can tell you something about that. But we're hoping in next year, I believe, 2025, that there will be some initial results there. And then what are some things to keep in mind while using the tool? Okay, so these are other things that are basically, how do you make important decisions in your life? You know, what else is important to you? Are there short and long-term effects? Do you want to know what happens as far as your time commitments and family commitments and costs and quality of life? So those are all things to keep in mind. And this tool kind of helps you through that. Now, before I go through specifics on the tool, and I'll try to do it very quickly because I have some results for it, could you please tell us in the poll question what type of DCIS you have? So we have low grade, medium grade, which is the intermediate, high grade DCIS, DCIS with invasive breast cancer, if you haven't had it, or if you're not sure. So those are all of the points that you have. So please fill that out. And Victoria's going to flash our results up there. Okay, so again, we have a mix of people. Thank you for joining us, and I'm looking forward. I see there are lots of chats and maybe a couple questions, and we'll get to those very shortly. So let me go through very quickly. The support tool, I actually put in an example. So not my own case, but I'm pretending to be a 44-year-old woman who has DCIS, but may not be sure. So initially it will ask you, have you heard of treatment options for DCIS? And you can answer yes or no to various ones. In this particular case, my 44-year-old knew about a lumpectomy, which is also sometimes called breast conserving surgery, radiation, and a bilateral mastectomy. So she had heard about all of those things, but not the other things. And then which treatment options would you consider? So this again is before information. We're just trying to know where you're kind of at in your thought process for everything. So that's how I answered everything. And then I answered that I believe women have a chance, an average woman would have a chance of dying that was high and 64%, because a lot of women do think it's high. And so, as you can see, 44 years old, and I didn't know my DCIS. So then you get information about what the available treatments are. As you can see here, they list with radiation, endocrine therapy, both mastectomy and bilateral mastectomy, and then some other information about active surveillance and how you can learn more about that. In this particular case, my 44-year-old picked that I wanted to know about lumpectomy alone, lumpectomy with radiation and hormone therapy, and I also wanted to know about a bilateral mastectomy. So those are the three things that we'll learn about. As you can see, you can learn about all of the different areas there. So in this particular case, the health risks for me are that a chance of a future DCIS or a future invasive breast cancer in the same breast in 10 years is what this chart is telling me. It's also telling me about my chance for dying of causes other than breast cancer in 10 years and my chance of dying of breast cancer in 10 years. So out of 100 women who get a lumpectomy only, and Shelley went through that, 71 will not develop anything else in that 10-year period. 13 may have either a future DCIS or may develop invasive breast cancer in their same breast. And 13 will develop, they may or may not develop future DCIS or invasive breast cancer. 13 will. 2 women will die of causes other than breast cancer. In other words, it won't be related at all to their DCIS. And 1 woman out of 100 would die of breast cancer. Now, this is based on history, right? Past events and things like that. So it gives you some information. In the lumpectomy plus radiation and endocrine therapy, you see 89 women won't develop anything, 4 might, 4 will develop a premature DCIS or invasive breast cancer. 2 will die from other causes. And as you can see here, 0 to 1 will die from breast cancer. Now, they didn't make a half a person, so they did include 1. And then bilateral mastectomy, these are the numbers. So it's not that no one will get breast cancer again, even with a bilateral mastectomy, but it is rare. So you can see the difference between lumpectomy and mastectomy, or lumpectomy with treatments are not that different. And then it goes through treatment options, and then questions that you can ask your care team as well. And with that, I will stop and let Meg and Claire have the stage.
That was perfect timing. Perfect timing. All right, so we had a lot of questions submitted with registration and a lot being submitted live. So we did put those that have been answered live by Dr. Hwang in the chat. So make sure to check out those. We got a lot of questions around the treatment and the monitoring of DCIS. And some patients, and I'm kind of grouping these together. So everyone, if you're feeling like I didn't get to your question, it's because it was asked multiple times in different ways by different people. But the gist of it is they're feeling pressure when they get that DCIS diagnosis, feeling pressure to get, have surgery, have radiation, start AIs. What are things that you can say to patients to help empower them? Because DCIS just feels, it's like it's not exactly cancer, but we want to help prevent it from becoming invasive. What can we say to patients to help bring some sort of clarity and comfort to empower themselves?
I'll take that question first, but I'm sure that Deb has a lot that she'd like to contribute as well. So I just want everyone to know that if you take a group of women who don't have a diagnosis of cancer, about 10% of those women will have DCIS. And that is just, 10% of us walking around out there every day have DCIS and we don't know it. So when it's diagnosed, it's kind of like you're uncovering something that may have already been present for a long period of time. So because of that, it doesn't really make sense to treat it like the house is burning down, because it's just a high risk condition that patients have probably had for a long time before it's ever diagnosed. Right now, the option of not doing surgery and just doing active monitoring like they do for prostate cancer is not considered part of the guidelines for how you treat DCIS. But I'm hoping that it will be at some point in the future. The things that are currently recommended for DCIS, like a lumpectomy or mastectomy or endocrine therapy, all the things that I talked about, are decisions that don't need to be made immediately. So that I would say that the most empowering thing that you can do is to seek multiple opinions, because everybody's going to have a slightly different take on this. And because DCIS is in that gray zone, there's going to be a lot of room for different people, including very informed, providers, to give different opinions. And so I think that's the one gift of DCIS, is that you get time to get second opinions, find somebody whose recommendations resonate with you and who has the same sort of health philosophy that you do. Deb,
And I would just add that I think the point that Shelley's bringing up is important. Second opinions, sometimes people get third and fourth. There are some types of DCIS that are fairly straightforward, but many times there's this gray zone, right? Especially in the intermediate. What do I do? And as Shelley's saying, getting multiple opinions can be helpful. It can also be somewhat confusing. So the thing to remember is what Shelley said is, how do you feel with that provider? Is that someone that you feel comfortable with? Are they helping you think through how you make decisions, and then helping you understand what your different options are and how that fits with different types of decision processes? So, like, do you want to go for the gusto kind of, right? Where you want to do everything you possibly can first off. Okay. That would be surgery plus maybe some of the other treatments, even if you might not actually need them. Whereas other women are like, I like my breasts. I want to keep them as long as I can. So I'm ready to do active monitoring. And I'm okay with, with getting a mammogram every year. By the way, when you have surgery, you may still be getting mammograms every year. So, you have to keep all of that kind of in balance and make a decision that's right for you.
And to kind of go along with that of treatment and things, we got a question. How does the radiation level from 2 times a year mammograms compare to post-surgical radiation?
Yeah, I saw that going by the chat, and I wish I had something a lot more quantitative to tell you, but the amount of radiation that you get from a mammogram is, I've heard it say that it's similar to living in Denver for a year. So, it's very little actual direct radiation exposure. The radiation that you get therapeutically to treat your DCIS or breast cancer is much higher than that. I mean, I'm kind of making this up, but I think it's on the order of 100,000 times more. So it is definitely in a completely different category of radiation exposure. And that's why it works, because it helps to remove, just completely eliminate any cancer or DCIS cells that may have been left behind during the lumpectomy.
I thought this was an interesting question. What is the role of the oncologist post-surgery, and how can I improve communication with them? And I think that brings up, how important that patient-doctor partnership should be.
Yeah, so important. And I think that's why Deb and I were kind of emphasizing the second opinion piece. At least 2 opinions. Probably you get to a point where getting more opinions is, as Deb said, just more confusing than helpful. But, I think surgeons are people too, and we have our own opinions and we have our own philosophies. And so it's really important and totally fine if you don't find that you click with the original person, find somebody else who you can talk to a little bit better, or who seems to share your same life view. It's not always going to be a perfect fit for the first person that you're recommended to see. So, I mean, I think that I really hate the term doctor shopping, because I don't think that's fair. I think it's just finding somebody who's philosophically in sync with how you view the world and your health, and how you want to approach, treatment for your DCIS. And I think that's really your best bet. In terms of how to improve communication, what the medical oncologist does, generally, the medical oncologist in most places give you some information and insights about whether you might benefit from doing endocrine therapy. And then there's yet a third team member who's the radiation oncologist, and they give you advice about whether radiation might be helpful.
So we also got a lot of questions around the stress of worrying about DCIS, and feeling like how much scanning is too much. How do you balance between that stress of scans versus, that active monitoring, and what are things that patients can do to try and, reduce the stress of worrying about this type of diagnosis?
I'll let Deb take that. You get all the hard
Okay.
questions, Deb.
Well, and I'm going to pass it back to you as well. But I would say, to reduce the stress, the thing to remember is that nothing in life is risk-free. Okay. Just living through life. I actually looked it up, and we all have a 96 point something percent chance of living every day, right? It's not 100%. So we have to kind of keep that in mind, and then think through, how much do you want this to impact your life? Yes, you have DCIS. It's something you're going to have to pay attention to, but you don't have to live in fear every day. Believe it or not, they're actually looking at lowering treatment for invasive breast cancer for early stages, and are finding that that is okay. So looking at active monitoring versus surgery for low risk women is actually, we're hoping, a viable option that will be proven by trials like the COMET study very soon. There are more and more women who are deciding that they can take a wait and see approach and get surgery when they need it instead of immediately on a diagnosis. There are also clinicians that are thinking about that. So you just have to figure out, what is my level of worry in my life overall? That will determine a lot of how you want to do things. And then, keeping up with what's happening on the research is useful. And that's why we like to have these types of webinars to give people updated information. Shelley, anything else?
No, Deb, I think just putting in the context of like living every day of your life, you're dealing with some level of risk is absolutely the right way to look at it. I mean, there's even after a lumpectomy, you saw from those risk calculations, you're still at risk for a recurrence. And I think what we're trying to do here is dial back 50 years of kind of ignorance or lack of information about what the DCIS prognosis actually is, and trying to combat this messaging that we've all had for 50 years that DCIS is a cancer and needs to be removed immediately. I mean, there are still surgeons who are saying that, and I think it's very antiquated and doesn't keep up with the new biology and information that we're learning about what DCIS really is. And that's hard work. I mean, that's taking something that we've all heard for our whole lives and saying, hey, wait a minute, that's actually not right, because almost 100% of patients with DCIS don't die of breast cancer. So it can't be that bad. So starting from like facts and extending from there about a new way of thinking about how to talk about DCIS, how to think about it, and how to design the best treatments for patients have to do with research and science, but even more importantly, it has to do with the patient and how comfortable they are, dealing with uncertainty in life, how much risk they're willing to take on to feel that they are intact and they, they don't have to take medication. I mean, there are many different priorities that people have, and I think understanding that is really going to be the key to making sure that patients stay healthy and happy and feel a sense of well-being.
Thanks,
So,
Shelley. We have one more poll question. So if you could answer this while we are wrapping up. I would also say that, if you live a healthy lifestyle, if you look at your diet and exercise and all of that, those are always useful choices. It's not going to necessarily keep you from getting anything, right? I mean, it does help with some things, but that is a healthy lifestyle choice to think about, not necessarily something to avoid invasive breast cancer or another DCIS event, because we haven't seen that that's actually made that much of a difference yet.
these programs, we get so many questions, and there were, still quite a few that we received live. So everyone, what we will do, because we definitely want to make sure that we get your questions answered, we may try and do like a pre-recorded Q&A of some sort. If Dr. Hwang and Deborah are available to do that, just to get some additional questions answered. And we will also make sure to link to those resources that were given throughout the presentation as well, once we send out our video that you can watch on demand. So I just want to say thank you so much, Dr. Hwang and Deborah, for taking the time to be here with us today, give us updates. And, DCIS is just, it's still very hard to, psychosocially like wrap your head around. And we really appreciate your time and dedication. And everyone, this was a 2-part series, so make sure to check out part 1 that is already on our website. And check out Share's upcoming educational programs. Our podcast will be starting up again next week in February. And also please make sure to fill out our survey at the end of this webinar. It'll pop up right in your browser as soon as the webinar ends. And just thank you. And they're all anonymous too. And that's how we plan our other programming. But we will work to get more of your questions answered. And we did get so many. And I thank you so much for being here with us today. Thanks again, Dr. Hwang and Deborah.
MC, I
Yes,
just
thank you
wanted
so
to give
much.
you- Yeah, you guys do amazing work, and I just wanted to have a shout out for you as well. And any chance to be in the same room with Deb, whether it's virtual or not, is a great day for me. So thanks for giving me that opportunity.
Well, thanks, and vice versa, Shelley, and we wish everyone good health.
Thank you. And this concludes our webinar. Bye,
Thank you.
everyone.